My name is Katie Moss, and I am lucky to be the storytelling lead for 2020 Mom. And it's my honor to introduce our next speaker, Dr. Kara Zivin, who is a senior health researcher at Mathematica Policy Research. She's a professor of psychiatry, obstetrics and gynecology, and health management and policy at the University of Michigan. She studies the impact of health policies on health outcomes for perinatal women, older adults, and veterans with behavioral health conditions. Please join me in welcoming Kara.
Hi, good morning. I'm so glad to be here and to hear all the stories and to hear just about all the different experiences that we have here and to share our study with you that we conducted at Mathematica last year. And this came out in time for Maternal Mental Health Week last May. It's available publicly on the web. There's also printed copies at the California Healthcare Foundation table right outside here if you're interested. And it's been getting a lot of attention, so I'm really happy to be invited to be here. And in fact, I have really exciting news that the peer-reviewed publication that we wrote as a companion to this issue brief as part of our work was accepted for publication last week at the American Journal of Public Health. I was really excited about that. And we had to do a pretty extensive revision to this piece because they wanted more details. I'm going to be showing you some data that we collected, and so I don't know exactly how it will turn out when the paper finally comes out in press, hopefully before the end of the year, this year of the mother. But it'll probably be another 12 pages worth of, fine-grained detail, so hopefully that will be useful for those of you who are interested in really wonky type of information of that sort. So going on from there, as I think I probably don't need to say to this audience, but I think, just as a, level setting of where we're coming from, maternal mental health conditions, as I'm defining it, using the term here, although I realize that the perinatal mood and anxiety disorders has snuck into a few slides, but by and large, we're calling this maternal mental health conditions, including primarily depression and anxiety, are very prevalent and common in the United States. And yet, over half of the women who experience this disorder do not get the treatment they need. So that's where we're starting from. So we were really interested, and through our funders, which I'll talk about in a moment, we're interested in the societal costs of untreated disorders. So this does not just include things like how much does it cost for a doctor's visit, but broader concepts. We really wanted to be sure that we thought about things like what happens when you either can't go to work or you go to work and you're not feeling very functional. What is the cost of that? Can we put a dollar amount on this to try to get the attention of policymakers, of insurers, of others to try and understand, the burden and the scope of this illness? So we created a mathematical model that quantifies these societal costs and puts them all together in a single model, and we specifically focused on the early years of a child's life. We were focused on both mother and child from conception to 5 years postpartum. And we did this intentionally because there are some studies that will focus on lifetime costs. And I do think that is important to think about the long-term consequences of this illness. But at the same time, we recognize that many people have the same insurance for only, say, a year or two. Insurers are not necessarily interested in the costs that are going to accrue when your child is 18. And so that we really wanted to focus the time period of this model on the years surrounding birth. So we also wanted this model to be able to be publicly available, and so anybody can reach out and ask. I'm happy to send you the details of the model, and I'll talk later about some of the different sources, and I've even communicated with some people here in the room, I think, about it, so it's been exciting to see who's interested. And then we just also, so that you are aware, in addition to the work that we did with my research team on this project, we actually had a multi-stakeholder advisory group that advised us. We met with them 4 times over 9 months in a virtual webinar type format where we showed them at each step along the way what we were doing to include in this model, and because there are a lot of decisions to make about what goes in and what gets left out. You know, you can't include everything, and so I'll talk about some of that as well. So basically what we did is we used what we call a cost of illness methodology to synthesize existing evidence. And so this is evidence that's either published through peer-reviewed medical literature or the gray literature online or other places, to try to gather a variety of different inputs into our model. And so the idea of this model was to try to understand what is the cost of not treating these conditions in the United States. Now, obviously, people might want to know how much it costs to treat, and that's a different question, but we wanted people to understand, you know, if we did nothing, what is happening here compared to, you know, women who do not experience these conditions. So as I mentioned, we looked at the first 5 years of a child's life. We did an extensive literature review, and we included 5 maternal and 9 child outcomes that I'm going to talk through here. So this may be a little bit hard to follow in a short amount of time, but I'm hoping at least the color coding can kind of guide you. Basically, we wanted to start with an actual conceptual framework and, you know, have some sort of ordering principles of what we thought this would look like. And so we wanted to include both costs and outcomes for women and children, and then look at how those led to 3 main areas of reduced economic output, of public sector costs, and to healthcare costs. So I've listed here the different outcomes that we explored in our model. And so, as I mentioned, these aren't just financial costs of healthcare, but things like productivity loss, maternal suicide, benefits, different types of financial public assistance benefits that women might receive. We also looked at child outcomes such as preterm birth, child injury, well child visits. So, you know, a variety of different topics that may be of interest when thinking about these disorders. So the punchline is that for each mother, the cost of untreated maternal mental health conditions is $32,000 for the mother and child over a 6-year period. And so when you break that down into the cost for the mother and the cost for the child, it's $19,520 for each woman and $12,480 per child. And so more than half of these costs occur during the year that a woman delivers the baby, but then, you know, the remainder extend through on the rest of the 5-year period. And so, and we did this model using a 2017 cost. So when you add that all together, according to the number of births in the United States, we estimated $14 billion, like billion with a B, this disease costs per year in the United States. So it is a really big problem, and I also am going to continue to contextualize that because sometimes it's hard to, you know, take these numbers, well, compared to what, right? So, but first I wanted to highlight which costs we were talking about. And one of the things I found interesting through this work, because you don't know when you start how it's going to necessarily work out, that productivity losses were actually the highest cost. So for women, and so you might have thought, well, what about healthcare costs? And those were up there as well as C-sections, but yet those losses to employment were, you know, a large contributor. And I think that maybe can make sense once you say it, but you don't necessarily think of it that way going in. And then in terms of child costs, preterm birth was the leading cost, then associated with child behavioral and developmental disorders. For, again, these are younger children, so this isn't even including what happens as children get older, and then also child injury. So this is looking at the same information I just presented in a different way, so you can see the relative costs. And again, as you see, the productivity losses and the health expenditures really dominate the proportion of costs that are associated with this illness in mothers. And then here in children, again, preterm birth is an important contributor to the costs, as well as child behavioral disorders. So just something to think about in terms of, you know, the relative burden of these different components. So here, what we did was, any of these estimates that we used, it could be very easy for a critic to say, well, why did you pick this article, or why did you pick this number, and people could debate about which numbers you wanted to include. And so we did what's called a sensitivity analysis to see, well, if we changed the range of across the different articles that we read and information we had, what would we find? And as you can see, even though our model with the estimates we included had costs up to $14 billion. Here, depending on what you consider the prevalence of maternal mental health conditions to be, there are competing estimates. Sometimes you hear 1 in 7, sometimes you hear 1 in 5, sometimes you hear 1 in 11. That starts to frustrate me because it's like, well, what do we listen to? But anyway, we tried to include those various costs, and you could see it could be up to $60 billion a year. So, I mean, it really is, I think, a staggering societal burden. So again, to try to contextualize this a bit, we went back and forth with our expert panel, like, would we compare this to cancer? Do we compare it to heart disease? And people thought, well, no, that's probably not the best comparison, because we really wanted to stick to other delivering women in conditions that people might experience in and around pregnancy. And so we came up with trying to use postpartum hemorrhaging and gestational diabetes as comparisons, just because at least it's the same population, the same life period. And as you can see, maternal mental health conditions are both much more prevalent than those other conditions and much more costly. So I do want to be sure to point out model limitations. As I mentioned at the outset, we had a specifically, focused time frame, which really just is another way of saying this is an underestimate of the lifetime burden of this illness if you consider the long-term, as we were talking about yesterday, the 2-generation issues associated here. We did not focus on the economic case for intervention, although I've been kind of trying to nudge various people that would be a really interesting study if anybody wants to see that done, especially, we have Sage Therapeutics here focusing on the new medication postpartum, which I think there should be an externally funded study for that, but I think it would be really important and interesting to compare that medication with inpatient stays, with electroconvulsive therapy, with various other different components that people could use to treat this disorder. Because even though there's some concern about the price tag for that medication, it's always compared to what. If the alternative is no treatment and you have all these long-term consequences, maybe that number doesn't look so bad. We don't question some other high-cost drugs for other conditions. But I'm going to try and avoid a soapbox here. But anyway, we did not do any primary data analysis. So by that I mean we did not go out and talk to women individually. We did not consult their, individual medical records, in part because we really wanted this model to have data that would be publicly available, and those records are considered private. We did not include non-maternal caregivers, and that was another big source of debate because, clearly fathers, partners, grandparents, other people have a role and also have costs associated with taking care of both the mother and the child who is involved in maternal mental health conditions. But due to scope creep, we really wanted to try to keep this model focused. But again, that's another area of costs that we probably aren't considering. We did not have the level of publicly available data that we had hoped to drill down to at a finer level on either geographic units or racial and ethnic disparities or those types of things. And we really wanted to only include estimates that we felt were really felt good about and felt were representative. I was also asked, since we're here in California, and California Healthcare Foundation was one of our funders, along with the Zoma Foundation and the Perigee Fund, to talk a little bit about our California-specific findings. So we actually have 4 issue briefs that are available. We have one that are national costs, and then we have one for each of those 3 states. And so here some of the numbers that we use are based on national estimates, but others we try to take account for things like the number of births in California. And so here actually found that the maternal mental health conditions are higher than average, the U.S. national average, and that here, and I'm having trouble seeing it, but almost 70,000 women in a given year in California experience these conditions. So just think of that. And they had similar top costs as our primary model, but Here, I just included the comparison we had to the U.S. general population and then California in particular. And again, you can see the prevalence here is higher in California. It's over $2 billion just in this state associated with not treating these conditions. Slightly higher costs as well for maternal and child care. And then, slight differences in the ordering of the most expensive outcomes. So our takeaway points, we included this number of the 1 in 7 women, and that was actually not from our study. That's one of the numbers that is included in a lot of publicly available material. I would argue it's closer to 1 in 5 and even more like 1 in 4 in certain subpopulations. But our findings really were that $14 billion for not treating this disorder in a given year, and that's an underestimate. And remember that more than half women do not get treated. So, so as I mentioned, we have these 4 issue briefs. I will show in a minute my email that people can reach out to me so I can send you more details if you want, and our forthcoming paper. Few quick reflections here at the end. So, the U.S. Preventive Services Task Force could implement more maternal mental health screenings and provide treatment if indicated. This would have benefits for women's health, their children's lives. It would improve societal productivity and decrease use of social services. So I personally hate having to make an economic argument of why we should treat this condition. I think we should treat it because we should just do that as a society. But for some people, they are more moved by these economic arguments, and so I think you can, effectively make that argument. And stakeholders can support not just screening. Screening is not enough because, as we know, identifying that someone has this disorder does not necessarily connect them to relevant treatment, and that's really what we need is access to care, quality of care, and affordable care. So I wanted to share, as I mentioned, we put out these issue briefs last May, so we're about 9 months into them being out in the world. And I still actually, even in the last week or two, I get people emailing me, asking me, saying, hey, I'd like to see about what would the costs be in Georgia, or what would they be in Montana, from public health agencies, universities, the March of Dimes, a variety of different people. And then actually I was really excited. So I live in Michigan now, and our governor cited our report in her State of the State address last week, where she was talking about trying to extend Medicaid coverage from 60 days to 1 year postpartum. And at the bottom of this document that said healthy babies and moms, she cited our issue brief. So and I didn't send it to her. So it's interesting that this is out there. People are learning about this information, and it seems to fill a gap that we had in the knowledge about this disorder. I show here, and we can circle back to this if you want, just the members of the advisory group that we had. It was really great to work with, researchers, economists, health providers, pediatrician, OBGYN. It was just a really great mix of input on thinking about this model, and I think it lent it some credibility. This wasn't just stuff that we made up in my research group, but that, we got a lot of input from others. So this is just, I wanted to acknowledge both my project team and the funders for this work. It was so exciting when they put out this statement for proposals. I personally am really committed to this work, and so I just had to do this project, and so I'm really excited how well it's turned out, and I think they've been pleased as well. I also wanted to, this is the hard part of this talk for me always, that this is very personal for me. This is my son. He turns 9 next week. And when I was pregnant with him, I was very severely ill. I tried to commit suicide by overdose when I was 8 months pregnant. He was a preterm birth. He went to the NICU, and I went to the psych ward. And I am extremely fortunate that I survived and that he survived. And, I have basically tried to spend my time since then trying to do this work. It's actually his birthday next week, which means that it's the anniversary of my overdose next week too. And so it's, But I'm here, and I'm trying to, I guess this disease knows no boundaries in terms of race and class and income. I saw both of my OB and my psychiatrist less than 48 hours before I took a lot of pills. So I can just tell you that this is real and it's important, and I'm so glad to be here and share this work, this data with you, but also the personal component. So for more information, here is my contact information as well as each of the funders and the link for the issue brief. And I'm happy to answer questions now or later. And thank you very much for your time and attention.
First of all, thank you so much for giving us a price tag. It's important with the work we do with Mom Congress, going to politicians. We needed this a lot. My question is there a way for you to create the cost per state and make that available? Because this would help in Florida.
No,
and
I would
sure
love
everywhere.
it too. And that part of what I've been doing is sending it to people and with instructions on how to do it yourself, because I don't personally have the resources. So hint, hint, if anybody would like to support us doing this for every state, we've thought about, could we make a dashboard? Could we, and I hate being up here talking about money, but, this project ended, and so unfortunately we've had to move forward. But I would really love to see that, because I think there is so much variation, and there's so many different other avenues that we could take. But in the short term, I'm happy to send along, and that's what I've been doing when people ask, well, hey, I want to do this in Georgia or South Dakota or whatever. So, yes, it is feasible to do. I would say for other states, it's again harder at more like the county level, but at least at the state level, I think we could do it.
Hi, thank you so much. I'm Harvey Karp, pediatrician. One of the questions I had is that the London School of Economics did a study on the cost of postnatal depression, and it came out to a number of about $9 billion for the total costs of postnatal depression. So it seems like it's quite a bit higher than the 2017 California study and the one that you put together here. And one of the obvious issues is that stopping at 5 years, because obviously
Yes.
the problem doesn't stop at 5 years. What was the thinking in going into that and trying to I'm just concerned people are going to hang on to this number as if this is the right number. Yeah.
So actually, Annette Bauer, who was the author of the London study, was on our advisory panel, and we specifically sought her out because that was one of the few data sources that we had prior to this work, and we still communicate with her. To me, very honestly, I would ask the funders are the ones who suggested to us we really want to focus on this time period. And as I said, it's my understanding, and I don't know if they're here in the room right now to answer, but I believe that, again, it was because we know that people switch insurance so often that if we were trying to make lifetime projections, it would really, people may not be as interested, in worrying about, okay, this costs this now, but, you're talking about 20 years from now. And yet I completely take your point. That people sees numbers, and so there's no perfect answer. We've tried really hard to be really clear. This is what is included. This is what is not. This is an underestimate, but I recognize that message can get lost sometimes. So I would just say that it's imperfect, but I don't. Again, I'm happy to do another study where we extend it out. If you want to do that, we can try that too. Yes.
I'm trying not to fangirl out knowing Harvey Karp is in the room because you saved my family. So I just had a quick question on your percentages for the number of pregnancies and deliveries with diagnosis. Did that include postpartum diagnosis, post-delivery diagnosis?
It's a good question, and I have to go, but we have like 100 different data sources, so I have to double check. I believe that our prevalence numbers were based on the PRAM study, so the Pregnancy Risk Assessment System, which is not, I'm missaying the acronym right now, but the CDC funded work, so that is where we got that, but also, and again, we were using prevalence estimates as opposed to claims-based diagnosis files, if that makes sense. And we were also pulling these out of the literature as opposed to, again, running a study and checking. So it's another imperfection of this type of work, which is another reason why we did the sensitivity analysis. But because we also did cover the post-delivery period, it should include that as well. And actually, PRAMS is, now as I'm thinking about it, because I have other studies in this area, you're asking people to reflect backwards on what happened during pregnancy, but you can also incorporate postpartum.
Thank you so much for this work. We've talked in the past, and it's been really wonderful to see this brought into California. I know that when I read the report, I was a little bit confused about the 2.4 billion and what that what the assumption underlying that was. And could you share with the group, because I don't want to misstate it, does that assume that none of the diagnosis or none of the prevalence was treated, or is that among currently in California the percentage of women who have maternal mental health conditions who are not receiving treatment? So what is the assumption there?
Sure, I know, and it gets complicated because we can't always know from the estimates in the literature what percent of women did actually get treatment and how effective with the treatment and how long and what was it, and all of those different components. So I think it is a valuable question of how that all came together, and I feel like I'm not going to do it justice. I feel like you always have had really great specific questions about how we actually came to all of these various numbers, which was essentially adding up, okay, here's a prevalence of this in this study, and here's the cost, so, prevalence of SIDS, or here's, suicide. So I think I'm trying to figure out how best to answer it, and I may need to punt for now, but I guess the point is that what we did not do is take, a bunch of women that, okay, here are all these people, we know for sure they don't have a diagnosis and they're not treated, and here's a bunch of people, they're treated, this is what they're, we were basically saying, okay, what would happen in all of these different instances of, what would be the productivity loss if you had this disorder but you didn't go to work across a population, and the same thing for all of the different estimates, but I realize I'm not giving a very satisfying answer. But the good news is that it will all be in great detail in our published paper, which hopefully will come out this year. But I'm happy to try to talk with you one-on-one to try to make sure I answer it better. Thank you again.